So just to review some postural analysis issues, we can do very quick scans of our clients before we get them on the table, just to kind of get some ideas about where some postural deviations might show up. I prefer to do a very quick scan from the toes up, and knowing kind of the general bony landmarks of what should fall on those lines, and what we should be looking at bilaterally as well. So if I were to take a look at Cari, I would ask her ideally to remove her shoes and stand with her shoulders, or feet about shoulder width apart, and just kind of shake it out. Let's see. Just kind of shake it out. Try and not hold any type of posture you think, but just stand as comfortably as you possibly can. And I'll just stand back and just do a quick scan up from between the space between the toes up to between the eyes. And I'm usually just looking for anything off that midline first of all. So running through the space between the knees, the pubic bone, the belly button, the sternum, through the nasal bone. And just looking to see, does anything jump out at me as being a little bit off. And what I would say, and not even quite sure if it's the shirt, that something's a little maybe off right through here, but I can't tell for sure, so I'll confirm it by looking at some other things. Once you've done that, I'll do a quick little bilateral analysis. So you want to see that the bony landmarks that match left to right are even from left to right. So I'm going to take a look at her malleolus. I can also check to see if she has a nice arch at the base of the foot, which can lead to a lot of things up above it if it's not appropriate or proper. And you should be able to stick your fingertips underneath the arches of the foot.
I don't think you can stick yours anyway.
So she's maybe a little bit collapsed down or weak in her medial arches. Check at the knees. I would also check to maybe see if there's any squinting of the patellas here. I'm just going to palpate your hips here if that's okay. Check that the levels of the ASIS are even, and hers are not. And maybe that's what I'm seeing above when I just looked at a quick midline glance. So her left ASIS appears lower than her right. And it's a pretty, to me, apparent difference there. We can also check the levels of the ribs. Come up here underneath the rib cage. Checking at the levels of the acromion processes, and another apparent difference there. Pretty obvious to see that her right shoulder appears dropped lower than her left. And it does appear a little more sloped through here than on this side. She also does appear, and I'm not sure if it's because you're looking at me, maybe just slightly rotated to her left in the neck or head. And that's just kind of really quickly what I'm seeing with her. And I wouldn't necessarily tell her all of these things myself, but I'm just checking to see that everything is in line as it should be, to give me some clues as to where your pain might be originating from. It's usually because of a pain complaint. All right, I would ask her to turn around, facing away from me. Okay. And I'll just take a quick look up the back. We're looking between the space between the legs, through the gluteal cleft, through the spine, basically to the top of the head, in terms of a midline analysis. And I would actually, if she gave me permission, feel her PSIS here, and then run along her SPs, just to feel that that's a nice straight line. I'm not sitting here palpating every single level, but just kind of running my hands up through here to feel that, especially if I can't see it through the shirt. And bilaterally, I can take a look at, again, the bony landmarks that run evenly from left to right. Because I knew that her hips were off anteriorly, I'm going to check the levels of the PSIS in relation, and they also do feel a little bit unlevel to me. I can check the rib cage here. I can also, your arms just hanging nicely at your sides, just check the space here to see that that's even from left to right. That can show a translation sometimes of the spine. Or a lateral flexion which I would want to make sure is not happening because of what I was seeing at her shoulders. I can check the levels of her inferior angles, and I do see that this shoulder is definitely, the whole complex is at a different level than her left side. Okay. And then I will also check the medial borders to see if there's rotation going on in the scapulas, which are dropping that shoulder complex down. And with hers, it does feel like everything is rotated down this way, which shows why that acromion process appears lower from an anterior view. Okay. I would probably also check the tension in the traps here, just because of the difference from left to right. Any tenderness in one side more than the other?
This one.
Okay. More tender through there, and that is actually, her trap would be weak in this case. So it's discomfort due to weakness, not discomfort due to shortening or tightening. Okay. She's not two wings, so I'm just going to check her pec minors in the front too. Very slight difference from left to right, so I don't think pec minor is like a major difference or problem for her. With the shoulder, it's something more that's happening here. So her levator scapula might also be short and tight, even though the trap is weak. Tenderness through there.
Where you first started.
Right through here. Okay. So tenderness due to shortening of the levator scap in that case. I might also palpate through the lateral scap. See if there's any contraction here. And then we can also just check for weakening in the rhomboids, any tenderness there.
Tickling where you just were.
Tickling. She had a little bit of hypertonicity, but it actually felt more through her erectors. Tickles a lot on this side? Okay. All right. Okay. And then we could do lateral views just to also take a look. So we'll just go to your left first. And just shake it out a little bit again. Okay, so again, I'm going to scan from the lateral malleolus. Should go about the head of the fibula, greater trochanter. There are some variations about whether that should be just anterior or just posterior too, but we're just generally looking where they fall in line with each other. Through the lumbar and thoracic bodies, and the C-spine through the EAM. The one thing I noticed maybe with her, she might be a little extended in the low back. And that's because I can also from a lateral view see that her manubrium almost appears posterior to her ASIS a bit. So from a lateral view, those should also be in line for a nice canister kind of stacked here. And so that's what shows me, it like almost appears as though like the belly's protruding just a bit, which is okay. We actually want that in a nice relaxed posture. We don't want someone contracting and squeezing in. But I do see that just a little bit, so I'm guessing that she might have some low back hypertonicity as well. Check her ASIS to PSIS. Can you also just place your fingers right on top of your pubic bone for me? And I also check the ASIS in relation to the pubic bone, and hers sits pretty nicely right on top of that. Okay. And then can I have you turn around to this side, please? And we'll just do a quick scan on this side as well. Same bony landmarks just kind of running up through here. And then I'll check her ASIS to PSIS.
And that should be level, pretty much, or the PSIS is higher a little.
For females, it can be anywhere from level to about 10 degrees of PSIS, a little bit higher than ASIS.
Okay. And for male?
It should be level. It can also be slightly anterior or dropped lower.
Okay.
Can you place your hand on your pubic bone for me really quickly? And we'll just check that as well. It's running down from here to here. This one actually might be a little more posterior than the other one is, and that might also contribute to the difference here in the left to right. Alright.
Do you check for like hyperlordosis or things like that?
So when I said your spine appeared extended, what I did mean is kind of like a hyperlordotic or excessive curve here, just a little bit.
So Cari,
We can also check for the curvature in the hyperkyphotic position. You might see an excessive rounding here, which we do with a lot of our older population here in the clinic. But what you'll also find on especially active people is that this thoracic curve has flattened. So it looks very straight and rigid, which someone might think, oh, that looks great. It looks like a nice, healthy, straight spine, but we actually need a little bit of curvature through there. The lumbar spine can also occur. That can also occur where someone becomes posteriorly tilted. If you can, just kind of push your feet. Yep. Posteriorly tilted, and then this becomes very flattened out. It appears as though they're really squeezing through their glutes here. Go ahead and relax out of that. Not the case with Cali. And then the only other thing I see from this lateral viewpoint is you can really see kind of Kali's sternum and this part of her chest. So it almost appears as though she's kind of rotated to us just a bit this way. I'm exaggerating her. Okay. So for Kali, my two primary concerns would be to get a little better level between the shoulders, or understand why that, if you turn back to the front, understanding why this this appears to be a little more dropped or downwardly rotated. Okay. And I will tell you my quick goals for her would be to get that scapula upwardly rotated. Since it's downwardly rotated, I'm going to do everything to get her upwardly rotated to create a better balance. Right? For the unlevel hips, I'm probably going to do a lot of joint play. Oftentimes just joint play and some really nice fascial holds will help to create a better alignment and balance pretty quickly. So we're going to kind of do that as well, just to see. And then when you were saying that you had ticklishness, is it just on your right side or is it on both?
I don't know. I was only on one side, so
Okay.
it was definitely on
You were
this side.
aware of it there.
Mhm.
So if I just kind of feel through here.
Oh, now
Probably
that's
not.
kind of tender the way you're doing it, but yeah, like
It's
right there,
tender.
yeah,
Mhm. And not as much on this
yeah.
side?
No.
Okay, so that difference from muscle tension from left to right or tenderness can also play a role in why the hips, why these seem to be a little bit out of alignment here. Okay. So those would be kind of my two goals for her, unless she was coming in with a specific complaint, which we can talk about how, you know, an imbalance in the shoulders might lead to a tendonitis and how we might go about treating that. I'm not going to say it appears as though you have a hyperlordosis or a hyperkyphosis, because that technically is diagnosing.
right.
But you appear to be a little extended through here, or this curve should be a little bit more rounded than it is, or this curve is maybe a little more rounded than it should be.
Okay.
That's what I'm seeing. So, and that's, I put it in terms of this is what I see, or I might say, with Kali, I see that this shoulder appears a little dropped or lowered, so I'm going to do some work to help create a better balance for you. Just some nice, quick balance improvement.
Okay.
And then I'll give you some homework that can help you to bring more awareness to getting into a more regular pattern with your movement and your posture. Okay. So with Kali, I'm just going to first ask her to really focus on taking her breath down into her abdomen right through to this space here. And as you continue to lie here, even though you're concentrating on maybe some of the work I'm doing, I really want you to stay focused on maintaining that nice breath down into your abdomen. Also, I want you to try and expand your ribs out laterally through here as well too, as you do. And then I want you to feel that your hips are nice and heavy into the table. Right, so just try to take any tension out that you're holding or guarding from here as you focus on some nice breath work. Doesn't have to be a lot of deep breath work, just a nice regular pattern that is focused and conscious and present. As I work to try to create some change here through the shoulders as well, I might cue you to bring your concentration or attention to certain muscles here as I'm working. Now potentially I could open up the shoulder just a little bit. So I might just start to work by pushing her shoulder back to the table. So it's just soft compressions, and for me it's just getting her joints where I think that they would be better positioned for her. Right, so we want the shoulder to be, the scapula to be upwardly rotated, and then we want these, the tension through here to just be nice and soft. So I'm just kind of working to open her up here. And I also am always thinking about getting my client into a nice parasympathetic system response, quieting the central nervous system out of that fight or flight. Just real light tractions. And then I'm taking her into upward rotation and also just creating a little bit of space or joint play between the humerus and the scap. But I'm not creating too much restriction here because I really want her scapula rotating up. I'm also just getting a little bit of rib joint play just to enhance her breathing. Making sure that the scapula is also freely moving from that area. Coming into her levator scapula here. So she's saying she's very tender, and I just want you to keep your arm here just for a little bit while I work. So I've passively kind of slackened that muscle by putting her like this. Even though it's technically would be considered stretched, I've kind of elevated her whole scapula up just to create some slack into her levator scapula here. And I'm finding where the muscle feels restricted, turned on, or facilitated. And she says tender as well.
No, you're approaching elevator.
The levator scapula, yes. Sorry, I was palpating it with my thumb. So with finger pads I can come in. And I can also just compare left to right. And there is a lot more tension held through there. So Kali, I feel like this muscle is really turned on right now, and I actually want you to start bringing some awareness to the tension that's in this muscle here. Focus on your breathing and bring your presence, awareness to here. And on the next few exhales, I want you to just consciously relax this muscle underneath my fingers. I want you to breathe that tension out of that space. Good. And it's actually quite amazing just getting someone to be able to do that, because it did decrease in tension as I was holding that. It may still be tender for her. It may still be, it may kind of kick back on again too. I'm not doing too much work here. I'm just kind of holding into it to bring awareness to it. Just going to come up here a little bit more. So I also have some tension right through here. It's the same muscle.
And you were saying that was the levator.
This is levator scale. Yeah. So Kali, it's time to get your brain to send this muscle another message besides fire, fire, fire. So as you exhale, I want you to think soft, 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 soft. Yeah, I'm just kind of pushing into it so she knows, she's aware of that tension. No, I'm just kind of holding here. Now I can also get her to fire it very lightly and then to soften out of that too. So that's a nice trick I have when people are holding tension, is to almost increase the tension and then relax out of it. So, Kali, I want you to just push your head into my hand really lightly here. Just really lightly. Good. Now relax and soften out of that. Good. We're just slowly trying to teach her muscles to send new signals to this area. And now I want you to feel your shoulders are just nice and heavy into the table here. I want you to turn your palms up here on the other side as well. I want you to feel your shoulders nice and broad and open. So picture a nice broad space here, nice and open through here. Nice breath down into your belly, expand those ribs. So just try to soften some tension through here. So here's where I felt that her left ASIS is dropped lower than her right. She feels tension on the right glute area, glute medius and TFL. The glute medius in particular, these anterior fibers, are pretty rigid. You might want to come to the head, Haruna. Give me all the weight of your leg. So I'm just trying to open up the hips. You guys can see I'm not doing a ton of direct tissue work. I'm incorporating some of that because I do want the client to feel like they're getting a nice massage. But my goal is to quiet the central nervous system, reduce just guarding and tension. Kind of just creating some traction to bring that hip down. So I'm tractioning down and just rotating medially because she was kind of turned out. It's as I was doing with her shoulders, I'm taking the joints where I want them to be. This one's dropped, so I'm actually distracting it up. And if I wanted to, I could distract this one up as I pull this one down.
Oh, cool. Okay.
All I'm doing is pushing my hip into her and pulling at the other leg. And that only works because of where her feet happen to be and where my hips happen to be. I wouldn't necessarily be able to do that, but you can do it with your hands. So I can push into her heel and pull on the other. Cool, you just bring it down into your hips right now. Feel them nice and heavy into the table. Probably want to get the head again. Probably want to be over here.
Okay.
So I'm just going into palpate where she had a lot of that tension. And it's already actually a little bit softer just by some of that work we've done. So Kali is really doing a great job of being able to tune into her body and be present in that.
Is that the TFL?
I'm actually in her glute medius. Her TFL is just in front of it here. So really, yeah, are you feeling that? Yeah. So I'm palpating around for any areas of tension, and her glute medius actually softened nicely on its own, but her TFL tickles and is held tight. So what I'm going to do is take a few breaths. It's time to bring your awareness down to this muscle and this tension and this site. I want you to focus on softening and releasing any of that tension held there right now. Incredible. She is doing such a great job at being able to just turn that up. Do you feel a difference there?
Just imagine the muscle melting.
Yeah. Awesome. That's great. And praise your clients. When you feel a change, that is great. Oh, that's great, Kali. Awesome job. Okay. And then I'm actually going to just draw her hip down to the table. So I'm just putting some pressure down. So once you have tension out of the hip, you can centrate it. And that's just drawing it to where it should be in that space. Sartorius and Mark right there, a little bit rigid still.
Very tickly.
Tickly. So I'm just going to shorten it, put a little slack into it. Breathe down into that space. Feel it soften. Why do you think this area is guarded?
Wearing heels.
Wearing heels. So your brain's telling these muscles here that it's always in heels.
Always. When I was like, gym shoes is like coming out of roller skates.
Yeah. Level. Right, sorry, her left is still just a little bit lower, but compared to where we started, almost practically level now.
That's good. Now you're not going to go in circles. Just kidding.
What I will tell you is that the more you can involve the client in the process, the longer and the quicker and the better the results will be. because I'm involving her brain as well. Instead of just passively acting upon her body. Noticed her arches were a little collapsed, so I'm just going in and kind of facilitating that a bit. Just palpating or giving a little bit of petrissage. Just waking it up. Also the fact that she's in heels all the time, she probably needs some attention here. Feel your hips really heavy into the table. Go ahead and breathe into my hands here. Feel our shoulders nice and heavy. Feel them broad. I want you to push your arm up overhead into my hands. I'm just going to give you a little resistance. Sorry, not here. I want you to try to raise your arm up this way. Okay, go ahead and do that. Go ahead, overpower me. Good. All the way. All the way. Good. Relax. Do it one more time. Overpower me. Why is she weak? Because her shoulder is downwardly rotated. Go ahead again. One more time. Up, overhead. Good. All the way. Can you go any further? Good. So I'm really getting her into upward rotation there. Okay. So I just facilitated the weak muscles, which will inhibit the ones that were firing that I helped her to shut off earlier. We could do a lot of work in prone as well, but that's just kind of a quick introduction into getting some nice quick change for your clients. Using some fascial work, using joint play, using conscious awareness or attention and muscle tension, using breathwork, if I haven't said that already, and then using kinesiology in terms of activating inhibited muscles to also inhibit the facilitated ones. To see if we could get some nice change. And on the table, her hips balanced out well. I can't see her shoulders in supine, so I might ask you to get up and we'll just see if there's any change there. So we can take a quick look at her again. Not quite, balanced out, but there should be some notable improvement there. I'm going to take a check here as well. So still a little imbalanced, but not quite as significant as when we initially went. I didn't do too much work to this side. I really focused in the tense areas. So that could probably use a little more attention here. And we did not do anything really into the back too much. So it's a good start to see that we got facilitated a small amount of change, that there's still a lot of work that can be done to facilitate even more change. Can you turn around away from us, please? I'm just palpating kind of through her traps. Is it
No
still
more tension.
no more tenderness or tension?
No more tenderness.
Yeah. Checking here. That is an actual pretty significant improvement in terms of where we first saw her shoulder, which was dropped down here. She is not quite as downwardly rotated and looks actually fairly similar to the other side now, which is kind of a nice result. We like to see that.
What would you tell the client, recommendation-wise, how long of a treatment to correct her posture?
She almost doesn't also appear quite as extended in her low back, probably potentially due to some of that breathing and having her breathe kind of heaviness down into her hips as well too. Mm-hmm. Probably won't be a long-lasting change since she wears her heels, but and interesting that it can change so quickly. How long? Sorry, what was the question, Rima?
After the assessment, after the process, what would you recommend applying? 4 times of a treatment continuously, once a week, once?
It's always really going to depend on what the client's financial situation is, their time allotment for being able to work longer term. But I would recommend weekly for a couple of weeks to see if we're getting some improvement, and then kind of reassessing. If they can afford that, that's what I would recommend. If they can afford to come once a month, then I would spend a lot more time after the session giving them specific homework instructions that they can do between visits, and I would follow up with them weekly to check in to see that they're maintaining that. So that would be on me to schedule a call or a text. I text with one of my clients in particular, kind of a couple days after I work on him, see how he's feeling, if he's keeping up with the instructions I gave him.
Sounds good.
Yeah, you can always work. But again, there are constraints outside of what I think is best, for Kali. But it doesn't mean that by her not being able to commit to more frequent visits that I can't give her all of the tools
Right.
I can to get longer term care, which will probably be more likely a reason for her to come back to me again and to refer others to me.
And that doesn't count as countertransference or?
Countertransference in which way?
We had this example, this scenario about a therapist who was thinking about how her client was doing and if she was doing her exercises.
Sure. So there's a difference between thinking about it and dwelling on it and wondering and being more invested in kind of the personal aspects of the treatments versus like measuring outcomes. So my goal of checking in with you is part of me scheduling my therapy with you.
Okay.
And I'm going to check in with you on this date to see that you're maintaining the recommendations that we made. And for that, and being really clear in that communication is not countertransference then. It would be if I had not outside of what we had agreed upon.
Okay.
So it's a good question. Yeah, no, it's a great question.
Good, thank you.
Yay.
Awesome, sweet.
Just the only thing in terms of tendonitis is I don't know what goals Sarah set for you guys when it came to that condition.
I think in general, let me turn this off for a second.
Yeah, have a seat here. So a question that arose is just to review potential general goals or guidelines for treating a tendonitis issue or a tendinosis issue, and within a time frame, let's say of a 25-minute, 30-minute session or treatment, so you can get right to the focal central issues. We'll use the long head of biceps as the first example, and then you can relate that information to other muscles.
Okay.
Ideally, my goals are to look at what is the shoulder posture and to try to get a better alignment of the shoulder posture, because that is most likely what is going to contribute to that excess wear and tear on the tendon specifically. The tendon will not just become inflamed for no reason, not even through overuse. The body should be able to withstand quite a lot of load and repetitive movement. So always checking to see that the shoulder is where it should be in alignment. But in terms of specific work that we can do to this site, we first must isolate out the tendon. So your first step is to isolate the tendon involved. So we'll say for Kali's sake that it was her biceps long head that she was diagnosed with as a tendonitis. And then through palpation, we've concurred that it's most tender within the bicipital groove and that lamina groove. Okay, so we know that the primary muscle involved with that tendon is going to be the biceps brachii muscle belly. And so ideally what you would like to want to do is to treat the agonist or primary muscle involved, treat its synergist muscles, which would be muscles that contribute or assist with that movement, and then treat some antagonist muscles or muscles that move in opposition to that, as they will also become impacted by that tendonitis. And so if we wanted to say, look at the biceps brachii, the primary muscle we would definitely want to get into the belly of would be the biceps brachii itself. I would also look at other muscles that flex the shoulder particularly, even though biceps is an elbow flexor and a supinator, its impact is at the shoulder. So I would also probably treat deltoid because, anterior, but especially because it covers that tendon. And you could also treat, say, the pectoralis major. Again, this is in the context of a 25-minute treatment, so we're narrowing down really quickly the focus of muscles we want to address in this session. It doesn't mean that they're all going to be involved, but it's where we're starting from. Okay, so pec major, anterior delt, biceps brachii. If they reported to me that the primary actions are coming from the elbow but creating stress at the shoulder, you could also treat brachialis as the secondary or the primary elbow flexor, actually. And then antagonist muscles would be, we could say posterior delt since we're treating anterior delt, and triceps, which is its real mirror muscle. Okay, and so in 25 minutes I would really do a lot of work to warm up pec major, anterior and posterior delt, and get middle delt since we're treating that as a whole. Getting into biceps brachii, and I would, when I say to treat these muscles, I mean generally warm, to do some myofascial release over the sites, especially over that site, that central site. To do some joint mobilizations where these muscles cross. And to search for and treat, either with deeper warming or trigger point work, those muscles that we mentioned. And then to get to that central tendon site and just get some sort of work addressed to it if there's no inflammation present. Sarah may teach you a frictioning approach as well, or a ice massage approach, which is a really good treatment, which is to take an ice cube directly onto that site and massage it rapidly until it becomes numb. Okay. We then want to finish off the work by stretching the involved tendon, not excessively, but just getting a nice stretch across the joints, and also stretching any of the muscles that we applied trigger point therapy to. Triceps, I could stretch this way. I just stretched her biceps this way. Stretching into extension for the pecs and brachialis as well. And then you can also do some kind of nice full abduction stretches to address that. That would be where I would start, and I'd check from feedback from her. If I'm in muscles that aren't really bothering her, impeding her, I'm not going to spend too much time there. And then we want to look for longer sessions and for a long-term treatment plan, how we get her shoulder into better functional alignment, how we get her to rest this area, to follow up and continue with some self-care at home that allows the area to rest, because tendonitis is really only resolved through rest and giving it a chance to recover. And so for some people that can be a challenge if it's a work-related injury, but then we can start looking at better functional movement for the client to at least get them to be able to facilitate other muscle use, to get to facilitate a better shoulder posture when using that side, and that's where I would start with.
Great. Thank you.
Thank you. So what you can do is you can take any muscle and think, and you could do it for any single problem any person has. Where their pain is, what muscle that might be, what its synergists are, what its antagonists are, and go in and specifically treat those muscles. And then see what kind of results you get.
Okay.
But to me, the longer term is to facilitate proper breathing and to bring the client's awareness to the areas of tenderness, to quiet all of that hyper-facilitation that goes on.
Great.
And even that stuff I was doing on your own hip is things you can do at home. You can lay on your floor and put your feet up on a coffee table and just focus on your breathing. Focus into the tension where you find it. Focus into softening that muscle. Because over time, your body will start to adapt to that new strategy. Leave the old.
That's good.
I know.
That's good.
Cool.
Thank you.
Welcome.